Now we have a session by Dr. Anshu on the enriching the curriculum by blending the arts and the sciences. And all of us know Anshu very well, so we don't need any introduction, formal introduction to be done. So over to you, Dr.
Thank you, Madam. You've all had a morning full of listening to things. I'm not allowing you to listen now. I want you all to participate now. Right? So let's try and do something interactive given the limitations of the seating arrangement here. Since this morning, we've been hearing about the health humanities. This is an era where technology is becoming supreme, and rightly so. We have clinical competence measured in the speed of diagnosis. But while the speed of diagnosis is becoming important, is there something we are losing out when we focus so much on science? Swami Vivekananda talked about the three arms of education, and he talked about the head, the hands, and the heart. We are focusing on knowledge. We are focusing on the head. We are giving adequate emphasis to skills in the form of the hands. What about the heart? Can you change somebody's heart? Can attitudes be changed? What about the affective domain? So you have seen different methods, and if you've been attending the last 2 days of the pre-conference workshops, there have been selected workshops on different ways and means of transferring this kind of knowledge of the humanities to the students. So let's try and taste the flavor of this by using a few different methods that are used in health humanities. What I'm going to do now, you want to look at all this? Admitting patients. Right. The reason why we focus so much on the health humanities is that medicine is not a linear subject. There is a lot of complexity. And when we teach, we usually teach in a straight form. When you actually encounter patients, things are not usually straightforward. Every patient is a complex environment. And then how do we convey this complexity to students? And one of the best ways of doing it is with narratives, with storytelling, with use of literature. So unless you're going to blend the arts with the science, this is not possible. So let me start off. This is not moving. Yeah, let's try and watch a film clip. This is a film clip from Tapan Sinha's movie called Ek Doctor Ki Maut. And I'm sure all of you have seen this movie, but let's look at one single clip from this. I hope it works.
कैसी तबीयत है? ठीक है सर, आपकी? हाँ भाई, क्या हुआ?
कुछ भी अच्छा नहीं लगता है डॉक्टर साहब, पता नहीं मुझे क्या हो गया है।
कुछ भी अच्छा नहीं लगता मतलब?
कुछ समझ में नहीं आ रहा है, लेकिन मेरी तबीयत और पहले जैसी नहीं है डॉक्टर साहब।
छोटी छोटी बातों पर आप अस्पताल में दाखिल हो जाते हैं ना, पता तो?
कई जगह सूना लगता है।
कमजोरी की वजह से हो सकता है।
नहीं डॉक्टर साहब, बिल्कुल सूना लगता है। ये देखिए।
चलो उधर चल के दिखाओ। Glove and stocking anesthesia. हाँ ठीक है, वापस आ जाओ। आ जाओ, लेट जाओ सर। Sister. Sister, इस पेशेंट को हॉस्पिटल से हटवा दीजिए। घर में तो जगह नहीं मिलेगी।
क्यों?
उसका पेरिफेरल नर्व अफेक्ट हुआ है, लेप्रेसी।
Thank God. लेप्रेसी?
आप एक नर्स होकर भी घबरा गए। घर वाले तो उसके पास तक नहीं आए। अथॉरिटी से कहिए ऐसा किसी लेप्रेसी होम में भेज। Leprosy, that damn menace to mankind.
Right. So what I want you to do is to go to your smartphone. You're allowed to use your phones in this session, whether it's a student or it's a faculty. So go to your smartphones, go to menti.com, click menti.com. And 1 minute, let this open. And use the code 24479625. Right? The code is at the top of the screen. 24479625. What do you think were the social implications of contracting leprosy in the 70s? This is a doctor who is working in the field of leprosy. You just saw this film clip, and you can give your reactions. Go to menti.com, and the code is on the top of the screen. 24479625. You may start submitting your responses. I think the internet is slow, but just keep continuing. Have you started submitting? Yes. I'm talking about the social implications. It's a stigma. People are scared to touch. You feel helpless. There is this feeling of shame. They thought it is very infectious. There's a social boycott. People feel like an outcast. There is a great deal of ostracization. It was thought to be contagious. Bahishkar. Shame, loneliness. I think stigma and isolation are rising there. Aloofness. So you see, using a method like this, it's easy to extract responses, get people to learn about what the different social implications are. I could change the question here. I could ask them, did you think the students, the doctor's behavior was good? I could change different things here, and then bringing different aspects other than just the clinical aspects here. So did you think the doctor spoke properly? Did he react well to the patient? Did he communicate well with the patient? I could change the question, but this is just one sample of it. So thank you for all your responses. Let's move to the next one. This is a poem, and this is a poem written by Dr. Preet Dhaliwal, and she's been kind enough to give it to me. It's been published in her book of poems called Inverse Medicine. The poem, let me read this out. It's called This Isn't My Normal. This wasn't always my normal. It isn't normal for you either, but it is my permanent. It is here to stay, a freak occurrence, a chance encounter with a vicious virus that threw my normal off kilter, a mess of atrophied limbs. While you cross your fingers and shy away from making contact with me, even though I'm not contagious at all, still, even your eyes don't look at me, and you never call it by its name. I wasn't born this way. Perhaps if I had been, I may never have discovered that my newly acquired normal is your abnormal. And I might never have noticed that your empathy feels like pity and looks like reprieve, but not for long this reprieve, because it's only postponement before your ability melts away from aging and from overconfidence, even as you design spaces and programs and whole countries where access is able-bodied, and it lustily ignores the fleeting nature of your kind of normal. What did you think this is about? It could be polio, because he's talking about a virus, is talking about a mess of atrophied limbs. So it could be that. So let's go back to your mentee screen there, and let's move to the next question and see what feelings were evoked in you when you heard this poem. You can enter your answers here. What feelings were evoked in you when you heard this poem? Sadness, empathy, sympathy. Is there a difference between sympathy and empathy? And the poem talks about why your empathy looks like pity. I'm talking about feelings, that they don't want sympathy. They feel stigmatized. And there is anger. There is a lot of anger in the poem. What does it say? In the end, what does the poet say? The poetess. My normal is your abnormal. My normal is your abnormal. And tomorrow when you age, you will also face this change. So you can see with one poem, there are emotions which are evoked, which might not come when you teach poliomyelitis. You say it's a virus which affects the limb and you don't bother about what is happening to the person. Unless you feel for something, you're not going to look at other aspects of it. And poetry is something which can help in getting in touch with that human connect which is there. It needs, sometimes poetry serves as a form of relief, where when you are stressed out, you can go and like a reflection. It is a release for you from your stress. So that's another thing you can do. Can we move to the next example? Thank you for all your responses coming in. I really like this part where it says that access is able-bodied. So how you easily stigmatize and ostracize a person when you just cater to one kind of normal, when everybody's normal is different. So let's go to, I just remembered when the Chief Minister was talking about the scare of injections, this picture came to mind. And this is a very famous painting by Norman Rockwell called Before the Shot. So look very carefully at this picture, and then I'm going to ask you the question. What did you observe about this picture? What are you looking at? This is actually in a small town in America, where a doctor is preparing to, you figure out from this painting now. What are the things you observe in this? Okay, can I move to Menti? Okay, what did you observe about Before the Shot, the painting? You can write, and use your smartphones and write. No privacy. I'll have to remove this and I'll show you the painting once more. This one? Okay. Right. Weak eyesight. Why did you feel that? A child taking an injection. What was the child doing? Want to see the picture again? What is he looking at? He's looking at what? It's a doctor's degree. So he's examining the doctor's degree. So yes, the child was distracted. The child, I don't know whether it is fearful. Your responses can be different there. A boy is curious. He's looking at the pictures on the wall. But if you look at it, the communication, the doctor, I don't know whether he's told him something or not. They're facing back to back. So one picture can evoke different responses. I mean, there's no correct answer. There's no right, wrong answer here. Your answer is correct, whatever it is. Somebody says it's an uncomfortable position to give an injection. I didn't think of that when I first saw it. The unsafe child, okay. Lack of informed consent. No human connect. Anticipation, that's a nice one. Preparing for an injection. Apprehension. I thought the boy looked curious. People think he's fearful. So both ways. So there are sometimes one important skill for medical students to have is observation. So using paintings is an easy way where you can teach the skill of observation, and it is also easy because when you use literature, sometimes the language comes in as a barrier. When you use a painting, it means the same thing to everybody. So there is no need for there's no barrier for language here. So I'm happy to see so many responses coming in. Let's do one or two more and then we can end this session. I'll do, okay. Okay, so I'm going to now read a narrative, and this is by Dr. Ranjana Srivastava. She's a famous oncologist in Australia. This is published in The Guardian. I'm just taking excerpts from the entire essay. I can't take the whole thing. So I'll just read this out for you. What is the hardest question a patient has asked you? A medical student wonders on a ward round. The question that I really struggle with is one of staggering simplicity and yet upsetting like a few others. Doctor, can I drink water? An elderly man looks eagerly at the drinks trolley. Affected by consecutive strokes, his limbs are weak, his face droops, and his voice slurs somewhat, although, if you focus, you can make out his words. After his wife's death, his health has taken a downturn and his days are sedentary. The first stroke gave him an unsteady gait, but he still enjoyed reading and sipping tea. A second stroke put him in a facility and led to a swallowing assessment that dictated a pureed diet and thickened fluids. When he protested, he was told that any instructions to alter his diet must be approved by a doctor. The residential care doctor refused, warning that thin fluids risk causing aspiration pneumonia. Now he is presented with an infection. When his children visit, he can't sustain a conversation, and everybody concedes that he is deteriorating. In a rare coincidence, he is awake during my rounds. When I ask, how can we make him comfortable? He responds by becoming animated and asking for a glass of water. Sure, I say, thinking that is the least of wishes to fulfill. He is not allowed, his nurse interrupts, pointing to the sign above his bed. Whispering a quiet aside to the nurse, the resident gets a cup of water and a straw. We raise the head of the bed, explain the risks to the plainly excited patient, and hold the straw to his lips. He takes a long drink and immediately starts coughing. He slows down and sips again. Satisfaction illuminates his face. Using his good hand to grasp mine, he proclaims, this first drink of water in 2 years as the best medicine of all. I note the glaring irony, considering the cost of hospitalization in tens of thousands of dollars. Don't stop my water, he begs, before falling asleep from the happy exertion. We pull down the sign and note that the patient, nearing the end of life, can drink water at risk. I want your responses. What did you feel when you heard this narrative? There are people who are remembering their own stories. Sometimes you know what is right according to science. But is that the correct thing to do, especially when it's a terminal stage of a patient and you can't fulfill somebody's last wish? This is one example of how impactful a story can get. If I were to ask any one of you, who are you? What would you say? We all are but a series of stories. Each one of us is a story. I'll finish. Right? So, and a good thing would be to use different stories and to get that reaction from the students. It usually doesn't work when you use stories from outside, and because the context has to be identifiable. And if you look at India, the wealth of literature that we have in all our languages is something that we all can dip into and take out these things. Each of us is a bundle of stories. And if you start writing those stories, writing those reflections, it helps you grow. And these stories also can work for teaching. So can I do one more or should I? Okay. So what I'm going to do now is I'm not going to ask you for a mentee thing. I'm just going to show how you can use these narratives to also teach about history. So I'm going to tell you a small account of smallpox variolation. And this has been written way back in 1767 by an East India Company physician called J.Z. Holwell. And he's talking not about Edward Jenner, but he's talking about how variolation of smallpox was done in India in 1767. I'm just reading that account here. We're saying that variolation was cheap, popular, and common. And how much they knew is what you're going to hear about here. Every year, so soon as the natural disease appears, which it usually does between the 10th of February and the 11th of March, the tikadars, the people who used to collect the scabs of the people who had smallpox, were called tikadars, began to inoculate. So they would take that small material from a smallpox lesion and apply it on the normal person. That is information that we knew in 1767. And the season for the inoculation continues until the 12th of May. The tikadar goes down one side of the street and up the other, and is thus employed from morning until night, inoculating sometimes 8 or 10 in a house. This intense intra-village coverage, combined with the movement of tikadars throughout Bengal, Bihar, and eastern Uttar Pradesh as described, leads one to think inoculation was perceived to be effective. When he has found a person under the natural disease, he opens the pustules with a rude iron bodkin and collects the matter on some cotton wool. He uses it by moistening the cotton in water and by rubbing it on the skin, and then in that part, he makes 8 to 10 punctures with a needle. Afterwards, he rubs the impregnated cotton upon the punctures. Children are not inoculated under 3 years of age, but generally before 10. Those who are too young for inoculation are carefully separated from those who undergo this operation. Very few indeed of those who are inoculated die even in the worst seasons. This is just one small excerpt, and I would urge you to go back and look at the history of how vaccination was in India of smallpox. And I won't ask you to respond here, but when you read that, you will realize there was a time when scabs were sold for money because you needed to have a scab from a patient of smallpox to be safe the next time. So that was the value of it. So some of our history is very interesting, and try and see, as Satendra said in the morning, how you can include these stories into your classes and make your classes come to life, I would say. In the end, I would like to acknowledge the suggestions and the help given by Satendra, Upreet, Dr. Sheshadri, and Ravi in designing this session. Thank you so much.
Thank you. Thank you, Dr. Anshu. Thank you for the excellent presentation and telling us how to use the humanities and arts, poetry, narrative to engage the audience and engage the students. Thank you.
Thank you.
Just a couple of comments.
Yes.
I was in the audience. I was asked to reflect. What you did was to use technology, even for humanity.
Yes. Yes.
By using technology, you ask participants to express their language. Language is important even in medicine. Irrespective of whether you use English language, Marathi language, whatever language that you use. The last narrative in which patient had a stroke. Now, for a physician, stroke would be stroke in some particular location of the brain, internal capsular or posterior circulation stroke, right? For that patient, stroke meant that the person had lost nasal sensation, then had developed paralysis, which means that could not breathe. Now that was for this patient suffering, which is different from disease, which happens to an organ system. And suffering leads to the feeling of loss of integrity of the individual. That is what bothers the person. What is going to happen with me? Thank you.
Thank you, sir.